At the core of appetite regulation lies the hypothalamus, a critical area within the brain. This region is responsible for processing signals that tell the body when it needs nourishment, when it has had enough, and when it is satisfied. Disruptions in this complex system can contribute to disordered eating patterns. Beyond biological factors, eating behaviors are profoundly shaped by societal and cultural influences. Historically, cultural ideals have dictated what is considered desirable in terms of body shape, particularly for women, contributing to pressures that can lead to body image issues and disordered eating. Looking at the numbers, anorexia nervosa has a lifetime prevalence ranging from 2.4 to 4.3% across all ages and genders. It's important to note that these disorders are not exclusive to women. Men account for a significant portion, representing about 25% of those with anorexia and bulimia, and 26% of individuals diagnosed with binge eating disorder. Bulimia nervosa has seen a decrease in prevalence recently, with a lifetime prevalence of around 2% among women. Onset typically occurs in late adolescence or early adulthood. This disorder is observed primarily in cultures that emphasize thinness as an ideal of attractiveness, highlighting the role of societal pressure. Binge eating disorder, or BED, involves recurrent episodes of consuming unusually large amounts of food in a short period. Unlike bulimia, it does not involve compensatory behaviors. BED is often associated with obesity, defined as a BMI of 30 or greater. In the US, nearly 40% of adults are obese, with higher rates in certain ethnic groups. Anorexia nervosa is characterized by a morbid fear of gaining weight or becoming obese, leading to a gross distortion of body image. Individuals with anorexia are often preoccupied with food, but refuse to eat, resulting in excessive weight loss. They typically weigh less than 85% of their expected body weight. Physical symptoms of anorexia can include hypothermia, slow heart rate, bradycardia, low blood pressure, hypotension, swelling, edema, fine body hair, lanugo, and various metabolic changes. Psychologically, feelings of anxiety and depression are common, and individuals with anorexia often become more introverted. Let's consider a key characteristic of anorexia nervosa. Which of the following is most characteristic of this diagnosis? A. Obsession with weight gain. B. Body image disturbance. C. Disregard for the feelings of others. Or D. Healthy family relationships. The correct answer is B. Body image disturbance. A core feature of anorexia nervosa is the significant distortion in how individuals perceive their own body. They often see themselves as fat, even when they are severely underweight or emaciated, which drives their restrictive eating behaviors. Bulimia nervosa is defined by recurrent episodes of uncontrolled, compulsive, and rapid consumption of large quantities of food over a short period, known as binging. These episodes are followed by inappropriate compensatory behaviors aimed at preventing weight gain, such as self-induced vomiting or the misuse of laxatives, diuretics, or enemas. Individuals with bulimia may also engage in fasting or excessive exercise. Unlike anorexia, most clients with bulimia are within a normal weight range, though some may be slightly underweight or overweight. Depression, anxiety, and substance abuse are frequently co-occurring conditions. Excessive purging can lead to serious dehydration and electrolyte imbalances. When assessing a client for bulimia, what finding would a nurse most likely expect? A. They are below normal weight. B. They binge when they experience hunger. C. They will be highly motivated to seek help. D. they are within their normal weight range. The correct answer is D. Clients diagnosed with bulimia nervosa typically maintain a weight within the normal range. This is because the compensatory behaviors, such as purging, are often effective enough to prevent significant weight gain, despite the consumption of large amounts of food during binges. Binge eating disorder, or BED, is an eating disorder that can lead to obesity. Like bulimia, it involves binging on large amounts of food. However, BED is distinct because the individual does not engage in compensatory behaviors to counteract the excess calories. Approximately 50% of individuals with BED also have a history of depression. The causes of eating disorders are multifaceted, involving biological influences. These include genetic predispositions, potential neuroendocrine abnormalities, and neurochemical factors. For instance, bulimia nervosa may be linked to neurotransmitters like serotonin and norepinephrine, while anorexia nervosa might involve high levels of endogenous opioids. Psychodynamic theories suggest influences like delayed ego development or an unfulfilled sense of separation from caregivers. Historically, family dynamics were heavily emphasized, but current understanding recognizes that while family involvement in treatment is crucial, blaming families for causing the disorder is not supported by sufficient evidence. Body mass index, or BMI, is a common tool used in assessing weight status. A normal BMI is typically considered to be between 20 and 24.9. Obesity is defined as a BMI of 30 or greater. In the context of anorexia nervosa, a BMI of 17 or lower is indicative, with extreme cases falling below 15. BMI is calculated using weight in kilograms divided by the square of height in meters. Formulating a nursing diagnosis for eating disorders involves integrating data gathered during the assessment phase with background knowledge about predisposing factors. This process helps identify the specific problems and needs of the client, guiding the development of a tailored care plan. Consider a client who is 5'8", tall, and weighs 105 pounds, takes laxatives daily, and self-induces vomiting after eating. What is the priority nursing diagnosis for this client? A. Ineffective denial. B. Disturbed body image. C. Low self-esteem. Or D. Imbalanced nutrition, less than body requirements. The correct answer is D. Imbalanced nutrition, less than body requirements. While other diagnoses like disturbed body image are relevant, the client's severe malnourishment and underweight status caused by purging behaviors represent an immediate physiological threat. Prioritizing nutritional status is essential to establish physiological stability. Desired outcomes for clients with eating disorders focus on restoring physical health and promoting healthier behaviors. This includes achieving and maintaining at least 80% of their expected body weight, having stable vital signs, and verbalizing the importance of adequate nutrition. Further outcomes involve the client's psychological well-being and coping skills. This includes verbalizing the events that trigger anxiety and demonstrating techniques to reduce it. Clients should also express ways to gain more control over their environment, reducing feelings of powerlessness, and show interest in others rather than being solely preoccupied with their own appearance. Specific outcomes vary slightly depending on the diagnosis. For anorexia nervosa, a key outcome is the client verbalizing that their perception of being fat was a misperception and demonstrating the ability to manage their life without maladaptive eating behaviors. For binge eating disorder, outcomes include establishing a healthy eating pattern for weight control and progressing towards a desired weight goal, along with verbalizing plans for future weight maintenance. Interventions for eating disorders often require a multidisciplinary approach. Hospitalization may be necessary in severe cases, particularly when there is malnutrition, dehydration, severe electrolyte imbalance, cardiac arrhythmia, or severe bradycardia, hypothermia, hypotension, or suicidal ideation. Addressing imbalanced nutrition and deficient fluid volume is a primary focus. Imbalanced nutrition means insufficient nutrient intake, while deficient fluid volume refers to decreased body fluid. Determining appropriate calorie intake for nutrition and weight gain is crucial. It's important not to focus solely on food itself, but on the overall health goals. Maintaining a strict record of intake and output is also vital. Denial, defined as consciously or unconsciously disavowing knowledge to reduce anxiety, is common. Establishing a trusting relationship with the client is paramount. It's important to avoid arguing or bargaining about eating behaviors. Goals and interventions should be clearly defined and agreed upon. For clients with obesity, which can be associated with binge eating disorder, interventions include encouraging a food diary to track intake and patterns. Providing instruction about any prescribed medications is also necessary. Setting clear, achievable goals and interventions collaboratively with the client is key to promoting sustainable change. Addressing disturbed body image and low self-esteem is fundamental. Disturbed body image is a confusion in one's mental picture of their physical self, while low self-esteem involves negative feelings about oneself or one's capabilities. Goals and interventions should target these issues, often incorporating techniques like concept care mapping and client family education to build healthier self-perception and coping strategies. Evaluating the effectiveness of interventions for eating disorders requires reassessing the behaviors that led the client to seek treatment. This evaluation process involves monitoring progress towards established outcomes related to physical health, psychological well-being, and behavioral changes. Significant behavioral change is often required from both the client and their family members for long-term recovery. Behavior modification is a cornerstone of treatment for eating disorders. Acknowledging that issues of control are central to these disorders is vital. For treatment programs to be successful, the client must feel that they have a degree of control over their treatment process. Successes in behavior modification have been observed when the client is actively involved in their care. This includes allowing them to contract for privileges based on weight gain, having input into their care plan, and clearly understanding the available treatment choices and their consequences. Clients can be given control over certain aspects, such as the specific foods they eat from a meal plan, the amount of exercise they pursue within safe limits, and whether or not they choose to engage in purging behaviors, though the consequences of the latter are clearly communicated. Staff and client should collaborate and agree upon treatment goals and the system of rewards for achieving them. Individual therapy is another important treatment modality. It is particularly helpful when underlying psychological problems, such as trauma, anxiety, or depression, are contributing to the maladaptive eating behaviors. Therapy provides a space for clients to explore these issues and develop healthier coping mechanisms. Family therapy, such as the Maudsley approach, is often crucial, especially for adolescents. This involves educating the family about the disorder, assessing how family dynamics might be inadvertently maintaining the disorder, and assisting the family in developing methods to support the client in promoting adaptive functioning and recovery. Regarding psychopharmacology, no medications are specifically indicated solely for the treatment of eating disorders themselves. However, various medications are frequently prescribed to address co-occurring symptoms like anxiety, depression, or obsessive compulsive traits that often accompany eating disorders. For anorexia nervosa, medications like fluoxetine, clomipramine, cyproheptadine, chlorpromazine, and olanzapine have been used, primarily targeting associated symptoms or promoting weight gain in some cases, although evidence for their direct impact on core anorexic behaviors is limited. In the treatment of bulimia nervosa, several medications have shown efficacy, particularly in reducing binging and purging behaviors. These include antidepressants such as fluoxetine, imipramine, desipramine, amitriptyline, nortriptyline, and the imawafenalzine,